I'd also like to thank the panelists. That was really terrific, and thanks for sharing your stories and your perspectives. We're almost done, but don't leave yet. Thanks, Karen. So I just wanted to again call out my co-chair, Lisa, who worked tirelessly over the last few months with all of us. And I wanted to ask the National Cancer Policy Forum staff to just stand because, frankly, none of this would have happened without them. We have Cheryl, Erin, and Cindy, and they kept Lisa and I more or less on track. We kept trying to get off track. They kept getting us back on track, and really made all of this happen. So they're always in the background, but they are the glue and the direction that got us where we need to go. So I want to spend just about 5 minutes, if I can, to just go over a few things. And you can't go over a day and a half worth of very enriched information, excuse me, in 5 minutes. But I want to end up in the last slide about what's next, okay? So just think about the types of things that I'm going to touch on as we go there. So this is one thing to think about. It's, you know, so we're a very biased group. You know, nobody came to this meeting who thought that navigation is a bad idea. You know, so this is not an unbiased group, but the question is, you know, is navigation good? Is it good for patients? Is it bad for patient retention? We've heard over and over again that's not the case. Are they bad for the economics of the healthcare facility? And we've heard a lot about that. So if these, in fact, are givens, why is it that Harold has been talking about this since the 1980s, and we're still struggling with trying to develop a robust approach to patient navigation in cancer in the U.S.? And so you got to ask the right questions, and that is a key question here that I think if we don't address, we're not going to be able to end up in the right place. Who should be navigated? And I'm not going to spend a lot of time on this. You know, Harold had a thought about this, and that we should really do targeted navigation because we're always going to have resource constraints. And I do think that that's the way we have to start, but I can't help but think about Linda's comments about not being in that needy population, but benefiting from navigation. Greg Simon saying the same thing. And if you're the Vice President of the United States and you need navigation for your son, there's a message there. So I think the early game might be targeted navigation, but the end game, my opinion, should be navigation for everybody. I haven't heard anybody who's not going to benefit from it. So I think that's just something to think a little bit about. Is there an ideal model for cancer navigation? And we've heard a lot of different models over the last day and a half, and so I think the answer to that must be no. Otherwise, people wouldn't be doing it in different ways. And there are different scenarios. I mean, what Karen deals with in Alabama and the surrounding states is different than what Tracy deals with in some of the needier aspects of Boston. And the programs may look a little bit different because the needs are different, and they should be created around the needs and not necessarily everybody having exactly the same model. I think that we do need to think a lot about role definition, standardization, training, and education. We've talked a lot about that even in the most recent panels, and I think we've gotten off to a good start with that, but we still have ways to go, and so I don't want to lose that. And then the final point, which Harold and others have made, is that you can't plunk navigators in the middle of a healthcare system and expect them to work well without them being part of a navigation program. And there's a difference between a navigator and a navigation program. And so that we need to design programs to help them be most effective. The other comment, which I meant to put on this slide, but in my rush to get these slides done this morning, I forgot, is that navigators may fill some of the cracks that are missing. And we saw that visual yesterday. but they can't be expected to fix systems that are truly broken. And so at the same time that we're having navigators try to bridge some of those gaps, we need to make sure that our systems are working at a level where they, in fact, can bridge those gaps, and it's not the Delaware water gap where they have no way of getting from one side to the other. Why is the financial model for navigation so obtuse? And Nick was great at talking about this, and others have talked about it. I don't think we can ignore this. I think if we look at a lot of the data that was presented in the last day or so, everything lines up in the same direction. You have increased patient retention. That's good for your bottom line. You have decreased resource utilization, and if you're in the right program like OCM, that translates into a better bottom line. We hear this over and over again. At my own institution, we did an ROI where the navigators, it was around, I can't remember who had the 10-to-1 ratio in this morning's presentation. I apologize for not remembering, but we came up with roughly the same thing. And yet, it's very hard to convince hospital systems to write that initial check and say, okay, I'm going to hire you 10 navigators because I know that ultimately down the line, we're going to get paid back tenfold for what we're paying them in salaries and benefits. I don't quite get what's missing in that equation, but something is missing in that equation. We struggle with it at my own institution, and almost everybody who's talked over the last day or so has talked about scrounging for grants and philanthropy and other ways to have navigators to run their programs. There's workload redistribution, having the right people doing the right tasks, and none of this will be worth it unless it's a sustainable program going forward. I do think that there are some things to think about, and this is just from Darcy yesterday, showing some of the parameters that are really critical from the financial point of view. There's a lot more in there as well. Outcomes. I worry a lot, and this was brought up again this morning, about having a navigator who's there in name only and is not, in fact, changing the outcomes of the patients. And these are just some potential outcomes that we might look at. They all have their own challenges. I don't think any of them should be the outcomes we're looking at in isolation. I think they're all important. You can value them different ways. But these are all measurable. I think the hardest one is the survival one, because you have to wait a fair amount of time, and when you finally get good survival statistics, it really reflects care delivered years before. But ultimately, these are critical factors, and I don't think we're going to get to where we need to get to unless we can show the outcomes, okay? Nobody in this country, the way things are going to give us things because we think it's a good idea and it feels good. Okay, we're going to have to show them the facts, show them the data. So this is my final slide. How do we move the needle? And how do we prevent ourselves from having the same workshop in 5 years? I'd love to get together with all of you in 5 years, but we shouldn't be having the same conversation. And I think for many aspects of care, I only know about cancer care, we've talked about things for many years before we've really seen significant movement. And Harold's been talking about this for nearly 30 years, maybe 30 years now, and we're still talking about it. So, you know, how can things look really different? I have to tell you that I'm old, and so I've been providing cancer care now for 40 years, and I've watched my colleagues, who I think are terrific physicians and nurses and social workers, but I've watched systems, and systems respond to money. And I think it's just one of the unfortunate realities of situations. I think we'd all like to change the way we practice, but ultimately, when I look at what's made things change, it's often the financial constructs around how we do our work. The Commission on Cancer, which I have the privilege of chairing, I think has helped the navigation world, because for the 1,500 hospitals who undergo accreditation from the Commission on Cancer, if they don't have a navigation program, they don't get accredited. It's as simple as that. I think one of the things in the Commission that we struggle with is, are those navigation programs doing what the last slide said? Are they changing outcomes, or is it a box that's checked and say, oh yeah, here's our 3 navigators, they stand up, everybody claps, and they get accredited because they have 3 navigators. So it's sort of the best that we've been able to do. Nina Miller yesterday talked about what's behind that, and we've tried to put language in there that make it real programs and not fake programs. But it's a struggle, I think, for our accreditation staff as they go around to 1,500 hospitals to really know in a day's accreditation site visit what's going on. But I think that's been a lever, if you will. I think the payers can be a big lever, and Ron Klein from CMS has talked a little bit about this, and Wendy this morning shared with us, I think, some very visionary direction from the Blue Cross Blue Shield Foundation, where they're trying to drive care and value-based care in a way that will make for our hospital administrators. It's nice to hear you say what you did, Linda, as a hospital administrator, Nick, drive them to do the things that they know they should do, but they're all beholden to a bottom line. Hospitals have to run in the black. It's the reality. If you run in the red every year, you're going to be out of business. And that's a reality, and it's becoming tougher and tougher to live in that reality in our current environment, and we all worry a lot about the political environment and how that's going to affect it. So I think that government payers, private payers can have a lot of influence in driving care, and there are many, many others. So as we digest what we've done in the last day and a half, I want us to think about things in this context. We'll be looking for more feedback. We want to create some documents that come out of this meeting. And we'd like this to be the beginning of a discussion, not the end of the discussion. We're anxious to work with the round table that you've heard a lot about earlier. This is not this is our territory, this is your territory. The only way that we're going to make progress is for the roundtable, for the payers, for the commission, for the National Cancer Policy Forum to try to work together and to force culture in this country to do what really our patients need us to do. So on that note, I want to thank everybody for being here, especially the speakers and our staff. Have safe travels home. Our work is just beginning. Thank you very much.